to focus in a little bit more. And then a few specific diagnoses that we'll probably run across most in both primary care and ER settings for that direction with it. Maybe. And okay. So the great thing about MSK medicine is really you can diagnose most things by history. So getting a very detailed history is usually helpful. And once you learn through kind of the different things that are the most common with it, those will hone you in, and then your physical exam confirms, and your advanced imaging is really for surgical planning with it if they need those things. So most things you can make with a few sentences that the patient is seeing. So whether there's a mechanism of injury or there's no injury are kind of most crucial. So if someone steps, plants, and their knee undergoes valgus and collapses in, and they're a younger person, so under the age of 40, your top things should be an ACL tear or meniscus injury with it, as long as they have kind of that velocity of force with it. If there's no injury, or if they're kind of 40 or above and they plant and twist kind of to one side or another, their most likely issue and diagnosis is osteoarthritis flare. So kind of knowing what happens with it is helpful that way. If they landed right down flat on their knee and kind of landed from the force, and they hurt all in the and there really can't be a lot of other things other than a patellar fracture or just a bone bruise with it. And so really honing in again with those three things and showing the patient what they did is really helpful to get you the best idea of what's going on. The time since injury is important, and so did it happen yesterday, and that's why they're so acutely flared up with it, versus did it happen 6 months ago and they just continue to have issues with it, and that's really going to guide what you're going to do for future management. Their handedness is important. So is it a person who plays a lot of recreational soccer and that's their plant foot versus their kick foot, for example, make a big difference that way on their occupation. And important to note kind of in the chart what they do with it. Did it happen at work also is important, obviously, for insurance purposes. But what are you trying to get them back to? So is it a person who has a sedentary job that they can probably work without any problem despite whatever injury they have, versus is it a manual labor who needs to do a lot of squatting, lifting, and then we need to do more either advanced imaging or kind of other more aggressive maneuvers to get them better from that standpoint. What makes it worse is really important, but probably more importantly is what makes it better. So typically with knee things, stairs, squats, lunges, all are going to make like patellofemoral pain worse and osteoarthritis flares worse, but usually you can't do those things at all if you have a more acute injury like an ACL or meniscus with it. The what makes it better and what have you tried are kind of the bigger things, because most people actually haven't tried anything despite them having this injury. So when we look at anatomy with it, knowing where to push is kind of the most important part. So going back and retrospect, kind of pulling it back out of your brain, so your quad tendon attaches to that patella. You want to push and palpate over the patella, and then with your patellar tendon going anteriorly with it. So a millimeter or like a thumb's length difference makes a big difference as far as location of anatomy versus like a meniscal tear versus an IT band if it's on the lateral side, for example. Your vastus medialis oblique, your VMO, is kind of the most important one, and so that's crucial because it controls how your patella glides. So everybody can reach down and touch their own VMO. If it's mush like there, you probably are going to have some knee pain at some point in your near future if you don't already. But if you don't have a teardrop right there, you haven't been completely adequately rehabbed with it either. And so that's going to control how your patella glides more in a neutral position as compared to going kind of more laterally with it. Your IT band runs around the outside, crosses over the lateral joint line, and attaches here on Gertie's tubercle in the front part of your knee. And so it's just this big band and that fans out. And so a lot of times that mimics lateral joint line pain or a meniscus issue. And so again, if you hurt on the joint line, go 1 centimeter up over that femoral condyle, and if that part also hurts, that's your IT band and not your meniscus, for example. When we look at the inside part of your knee, you got several structures kind of there with it. And so, it doesn't show up now. The things you want to look for in the inside part of your knee are your ACL is going to cross from front to the back, the femoral condyle is to get plateau. Your PCL is going to make an X behind it, and then you've got your lateral meniscus, which is more O-shaped, your medial meniscus, which is T-shaped. Those are the only 4 things that can cause a knee effusion if injured, besides the bony articular cartilage. So if you have a knee effusion, one of those 4 things plus bony cartilage are the issue with it. So if you do not have a knee effusion, you have not injured one of those 4 things. The other part of it is your MCL is on the outside part of your knee. Your LCL is also on the outside part of your knee. It does not connect to the knee joint. So if you have a knee effusion, you did not just injure your MCL or LCL. You injured something else on the inside part too. That being said too, if you just have an MCL sprain, you should not have a knee effusion. So opposite or active correct. The back side of the knee, again, you can see your ACL and PCL crossing this direction, and then your popliteal tendon coming across this side with this. So I'm going to draft my with exams, biggest thing you want to do is kind of look at both knees. You've got 2, so getting both of them exposed are the most helpful with it. Just up first, and then pull both feet like this.
What's up?
Pull your feet like this. So with this part, you want to look and see both knees with it. So if they're in pants or jeans, you want to get them into shorts or down to drape with it. And the same way goes if you're looking at anything else too, so shoulders or anything. Because a lot of things are subtle as far as sometimes they just have fat knees and that's symmetric. Sometimes one is fat and one is actually an effusion. So helpful to look at that way too. Otherwise too, you want to see your bony landmarks. So you've got skinny knees. So it works out. So you want to see the landmarks kind of on each side with it. So the other thing you can see is he's sitting very comfortably sitting up with me. So more than likely he does not have a significant knee injury because his legs are sitting over the side and just hanging there with it. So he's pretty comfortable from that standpoint. When you do it, I always sit like straight in front of the patient to examine a knee. I'll just stick to this side so you guys can see with it. But you want to just start again with palpation. So you're going to start from the front and palpate over their quad tendon attachment, straight down the patella, straight down the patellar tendons, that tibial tuberosity. Anything hurts kind of through there, it's usually that patellar tendon. And then that also gives you landmarks to feel the joint line. So you're going to feel on the medial joint line with it. And so a meniscus tear, if they're younger, is going to be the posterior medial aspect of that joint line. So if it hurts up here, that's not meniscus. If it hurts back here on that joint line, that's more concerning for meniscus. And again, that's going to be a patient less than 40. If they're over 40, it's all degenerative anyways, so you really don't care if their meniscus hurts, but that's arthritis related. The lateral aspect of the knee, kind of same way. So you palpate the joint line all the way across. And so joint line is here, as you can see, but 1 centimeter up is IT band. So if you feel like they hurt here, go 1 up, which is literally a finger breadth. And if it hurts up here too, that's again IT band, not just related to that lateral joint line. Next thing you're going to do is check their range of motion. So just have them extend their knee all the way out, and you can get to 0. And then kind of flex it backwards and see how far they can go and make sure it's symmetric that way with it. The other thing I do usually when they're seated is do an anterior and posterior drawer. And so with that, you want to scoot symmetrically straight in front of them, have them relax their leg. You grab with your knees, and then you want to grab the upper part of their tibia on the tibial plateau, kind of right around the tuberosity is the best location, and then pull forward. And so he's got a nice anterior drawer. What this does to do it while you're sitting is it takes away the hamstring warning. And so then they can't really lock down with it when their legs hanging over the side. Posterior drawer is the same thing. So you lock them in pretty tight and then push backwards with it, and you get that posterior drawer this way. If you're ever doing a knee injection, I also recommend doing it that way. And so you want to lock them in with both knees, turn to about a 45-degree angle, because most people do this when they get their knee injected. And so that puts them at this cockeyed angle, and you're going to hit their femoral condyle with it. So when you do them that way and lock them in, they're going to not be able to do that. So you can kind of aim that direction with it. So those are the kind of things to do seated. And then lay down. So if they're laying or if they're seated, we start doing the seated exam. If they're laying down or sitting on the table with their legs back, just start with the laying down exam and move to the seated. So kind of making use of whatever they're doing as far as time goes. With this part, this is where you want to check from both side to side. And so looking at, he's got good dimples around his kneecap. So you always want to examine the knee of the side that you're on. So I'm showing you from behind just so you can see with it that way. But for left side of the knee, I want to come to the left side of the table, for example. So to check your knee fusion, you're going to push down about 3 to 4 centimeters up above the top of the patella, and then you're going to milk towards the kneecap with it. You can see this is just tissue and skin. When you have a knee fusion, you're going to lose these dimples through here, and the kneecap is going to not be tight to the finger with it. So it's going to feel like there's fluid underneath and feel like it's palatable. Some of them are very subtle, some of them are just fat, and it's hard to tell the difference. So when you do it and milk from the tap, so you got to use quite a bit of pressure to push down with it, and when you do that, that's going to hold all that fluid if there is a suprapatellar infusion with it. But you really, again, want to check the opposite side and check and double check with it. So it should be tight against the femur when you're doing this side-to-side motion. That's how you check for knee fusion. From there, do a patellar grind, and so you just push on the kneecap, both sides, with it kind of here, and then you can go from side to side again. If that causes any pain, then you know there's some irritation on the back side of your kneecap, so either patellofemoral pain or patellofemoral arthritis with it. Patellar grind is you're going to push on the kneecap down and push from side to side with it, so you just use more force to do the same thing. Don't do that until you do the milder version first, because otherwise they'll not like you very much after that. From there, kind of do a couple of things. So those are pretty mild procedures. If they've got a pretty big swollen knee, you want to go gently, but you do all the work and they completely relax. So the best way to do that is grab from their heel, and you have complete control of their knee that way, regardless of how large the patient is. You have control this way. When you hold at the angle, you don't have much control of the leg whatsoever. So hold from the calcaneus when you do it. Put your hands on the joint line this way, and then you're going to pull in to check for flexion and see what that number is. So it should be 130 to 140 is a normal, and then all the way out to extension. So he's at 0 this way. Important to note from both sides, because some people are hypersensible. So an easy way to check for that is to check their elbows. If they go out past straight, you know that they're hypermobile or EDS type 3. So 1 in 5 people are, so 20% of the population are. So a lot higher, so look for that with it. But their also knees are going to be more mobile, like if their elbows go out past straight too. So checking for that range of motion, kind of with it first. While I'm here and kind of have my hands on the joint line, you want to do an overhand grip with that, is to do McMurray's. And so with that, it's going to be sensitive for meniscus. You want to flex their hips to 90, internally rotate, externally rotate, and then you bring them out in extension this way. So again, in here, externally rotate, internally rotate, and then an extension. Sometimes you feel the kneecap slide, and that's what's causing the pain. So a true passive McMurray's is you're going to feel the meniscus flip up against your fingers. So that's why you got to hold on the joint line with it. If it just causes pain, not a big deal. Lots of things are going to cause that, arthritis, patellofemoral issues. But you really want to feel that thing go up against your finger. Is a true meniscus issue. Not a very sensitive test. Your 2 more sensitive tests for meniscus issues are knee fusion and joint line tenderness. So if they have those 2 things with that injury, that's what you should be thinking of as far as meniscus issue. Otherwise, in an acute injury, again, usually a younger patient, so less than 50, is allotments to check out for that UCL. So with that, usually most people are tight, and so you want to kind of roll their hip. So I just internally, externally rotate their leg. You want to bring them up to 30 degrees, and they're always going to try to help you, but you don't want to do that, so relax. You're going to grab their femur, grab their tibia, and pull forward. And so it's a lot of force, but you're doing this motion with their leg with it. One of these days, you'll do that, and it'll just keep feeling like it's going. So the more normal you feel, it should feel like a rubber band snapping kind of underneath your hand, and it should feel nice and tight if you got them relaxed and loose. and so his is nice and tight. The other way you can do it is to put your leg up under their hamstring and get them at this 30, and then they're automatically then can't guard and squeeze down and lock down on you, and you do the same maneuver with it that way. So those of you who are close enough, you can see his moving just a tiny bit. You can do anterior and posterior draw this way too. So you're going to push it out this way. You want to have them turn their toe out, and then you want to sit on their foot so that they're not locked down. And so anterior drawer, you can see that move, and you can see how much he's moving, which is that kind of force you need to be able to do this correctly, and push down on it the same way. Okay. Other patellar tests, so those are kind of the main tests that you read about and see. Again, those are all you want to do in like people less than 50. Over 50, it's pretty much always going to be arthritis, so you don't have to worry about a lot of those other things, but good to get your hands on them and feel what they feel like. Patellar tests, kind of for other things, are the patellar grind. So when we push down and push on that knee with it, and then quad inhibition. So similar to how you're doing the milking maneuver to push that patella down, that fluid down. You're going to put your hands right on the top of the patella with quite a bit of force. Have them squeeze their quad. And you're going to hold that kneecap down. If you're practicing on a colleague, don't do that very tightly because pretty much everyone's hurts. But that's the patella gliding over that cochlear groove, and then it causes that irritation to the backside of your kneecap. So the stronger your VMO is, the more that keeps it neutral so it doesn't pull so hard over it. That's why it's the treatment for patellofemoral issues. Kind of controls that knee. That's everything. I didn't say anything. Other ways too, just kind of check your plantar flexion, dorsiflexion, check your sensation, posterior tib, or posterior tib pulse. Make sure it all looks good distally. But other than that, that's pretty much the questions about any of that. Perfect. Thank you. So when we look at knees, this is what a knee effusion looks like. This one obviously does not, so you can see the dimples nicely around their knee. This is where you lose the dimples, so not just fat knees, because you lose the dimples around it. So some people do have that tissue mass that summates kind of over the top. But again, everyone should have dimples to the side of the kneecap, so kind of looking for that. So causes of effusions in people less than 40, this is the order of frequency. So ACL tear, patellar dislocation, meniscal tear, osteochondral fracture, meaning bad bone bruise. And PCL tear is not very common whatsoever. And then bleeding, like hemophilia, that bled into it. And then arthritis for those 40 and above are probably the most common, definitely 50 and above. With this part of things, you can also help delineate as far as what time the injury was compared to what time they got the effusion. So if they had a planting and twisting injury, such as had a few people like stand up from a chair and they twisted to go get something, it's always going to be the lateral twist. If they swelled immediately, like within the first 4 hours, that's usually more of a patellar dislocation or osteochondral injury. If they swell more the next day, that's usually a meniscal injury or ACL injury with it. So kind of asking when that happened. The other thing you want to know is, did it blow up like a cantaloupe is usually my comparison size, or was it just a little puffy? And so that's also a good differentiation to say as to what happened. So your cantaloupe sizes are going to be like your patellar dislocation or fracture side of it. Your smaller ones are going to be more your meniscal injuries with it. The other thing is some people think it swells, but it's actually more soft tissue swelling. So they ask them where it swelled. So a lot of people say it swelled in here with it or out here, usually medial. And so if it just swelled on the inside, that's not a true joint effusion. They're just saying it was swollen, so that's more soft tissue. Talked mostly about this with it. So if they don't have an effusion, again, it'll be patellofemoral pain or like an MCL sprain if they had an acute injury. So again, intra-articular structures, ACL, PCL, medial and lateral menisci, and articular cartilage. And so these, again, issues are going to cause that knee effusion. And you can kind of read most of that stuff. But medial and lateral menisci, the palpation is the most sensitive. So really press on that joint line. Use quite a bit of force when you're pressing, and that's going to be your most sensitive test. The extra-articular structures are going to be your MCL and LCL. So your MCL, you've actually got two structures, two attachment sites. The superficial is the most common one to sprain, and those are the ones that get better in about 4 to 6 weeks. So acute injury where you get tackled by a dog, most recent guy I had with it, he had a very 150-pound dog come and hit the outside of his knee and press his knee inward. And so that causes that stress on that MCL and causes that pain with it there. Very rarely, almost never do those get surgically fixed unless they have an associated like ACL with it. LCL prevents varus opening, and so you want to stress them at both 0 and 30 degrees. With it, the LCL is rare / never occurs in isolation. So they're also going to have typically an ACL or PCL tear with it. So if they have that lateral pain, you think it's more LCL, they don't have an effusion, it's actually probably more ITBN because an LCL tear just doesn't happen. The patellar testing is the grind, the quad inhibition, and then JSON I didn't show you, but you want to have them seated, kind of with you doing it this way, and you just have them watching the knee extension. So they just straighten their knee out like this, and you want to watch how the kneecap tracks. So if they go real slow like this, they're not going to do it. If you have them go at a normal speed, that patella is going to come out to here, and kind of you'll see it twist just at the very end. So that's a positive J sign, meaning their VMO is not strong enough to hold it neutrally. And so that's you're going to find a patellofemoral pain issue. So when we talk about imaging, x-rays are cheap, inexpensive, and really have little to no harm. So if they're having pain kind of really for any real significant period of time, an x-ray is a very simple thing to do and kind of see what's going on with it. So with that part of things, you always want to order a 3-view, but the standard 3-view is AP, lateral, and oblique, which is what the ER gets all the time, and the oblique view is completely worthless. So right in there, or if you're having your own practice and with your own x-ray tech, so you want to do an AP, a lateral, and a sunrise. So the sunrise is this view and gives you much more information about the patella. So if you're ever in the ER, please order that for the rest of us. Otherwise, kind of doing that in your own, as far as when you're on the outside of the UK. So with this, if they have an effusion, you definitely want to get an x-ray. If they haven't had an x-ray in the past year and they have any kind of knee pain, that would really be a good idea. And if they have an acute injury, those are kind of the 3 reasons why you would want to get an x-ray, like right off the bat the first time you see them. Otherwise, if they've had one kind of in the past year and it's been the same chronic, it's not really a need to get a repeat x-ray at that point. So things that you can kind of see on these x-rays. So you want to look on the AP view, you want to look at the joint space from side to side, and you want to look for this white line, which is called sclerosis. So even if you don't see a lot of osteophytes, the sclerosis is the first sign of osteoarthritis, and a lot of even 20-year-olds have that. So just know that the cartilage is wearing a little bit there. The lateral is helpful for a few reasons. So you want to look if they get a true lateral, kind of at the shape of the femoral condyle. So if they have a big divot taken out the front part of here, that's kind of a sign of an ACL issue or deficiency with it. And then you can also look at how close the kneecap is to that femoral condyle, so you can see if that's causing some pain. The sunrise is the other important part, so looking at how it is behind here, and then if you see any irregularity with it. Some people who have like a patellar dislocation, or most people, chip off this little section of bone right here, and that's because that's where the ligament attaches. So you'll see a chip of bone hanging out over here, and so that's like a slam dunk that they dislocated their patella. An MRI to order is really with a young patient, so less than 40, with an effusion, and they don't have any significant OA noted on x-ray. So if you get their AP and they're bone on this side, even if they are 35, which sometimes happens, you don't really need to get an MRI because they've got bad arthritis with it. But if they have knee x-rays that look pretty similar to this, which is like null to no arthritis, and they have an effusion, good thing to get for that patient to see what else is going on. And so why that's important is meniscus degenerate over time, just as we age. Obesity increases that risk. And so we're not going to fix the meniscus in an old person. We're going to do a knee replacement. So we treat them like arthritis. If we've got a young patient who's in their 20s or 30s and there's a meniscus tear, we want to fix that meniscus if we can in order to prevent the progression of arthritis, so they don't need a knee replacement at all or earlier, kind of with it that way. So when we talk about differential diagnoses, the most common, hands down, is called patellofemoral pain. It's also called anterior knee pain, chondromalacia patella, runner's knee, but it's a functional issue and not a structural one. So it's a patellar tracking issue with repeated flexion and extension with a loaded joint, causes irritation of the soft tissues around the patella. So if they're just sitting and they're extending their knee, they probably don't have a lot of pain. But anytime you put weight on that knee, such as stairs, squats, lunges, that's what causes that pain. Otherwise, the other kind of test question cue is when they're the theater signs, so when they're sitting in a long car ride with their knees bent, sitting at their desk for a long time with their knees bent, that's kind of the other tip-off, which is called a theater sign, usually in your question stem, that causes this patellofemoral pain. So if you make a diamond with your fingers and you put it over your knee, over your patella, anything within that diamond is PFP. So good way to know kind of if there's a meniscus issue, they have joint line pain, and it's up here, this is not meniscal issue. So again, joint line pain is going to be back here that you're concerned about meniscus. So you want to treat it again, kind of all that direction with quad strengthening, hip strengthening in that direction. But good way for anatomy, kind of based on that part. So intrinsic risk factors for PFP, and so good things to look out for. So hypermobile people have this again. So again, just ask them to straighten their elbows. Genu valgum, which is what this picture is saying. So people who are knock-kneed, which is also why females are more predisposed because the hips are wider than their knees. And so they just come in like this, and that's how they walk and how they do things. So it sits their patella more laterally. A lateral pelvic drop, so it's a weakness of the glute medius and abductors. So you can have them walk, and if they do the model walk, but if they throw their hip out this way, that's going to be that weakness of the hip abductor, which is going to cause the knee pain. Similarly, you can have them do like a stork test. So if you have them stand on one foot with it, if they throw their hip out to their side, that's the hip weakness issue. So kind of making sure that they go from side to side with it and they stay straight on, and so they don't have that pelvic tilt. The other thing to do is have them stand. So if they have really flat feet and their feet roll in like this, that's again going to predispose them to getting that patella laterally. So getting them in shoes with good arch support or custom orthotics typically helps it that way too. When you look at their knee and kind of inspecting it, again, just look at that VMO. So if there's a lot of atrophy, that's something to work on with straight leg raises. And then just looking at the patella position, and so that's why it's helpful like on those x-rays to see where it sits in the sunrise view. If it's tilted laterally, that's going to predispose them. So clues from your history that it's that is bilateral knee pain. Females, usually teenagers to 30-year-olds kind of have it the most. Months to years of pain, no injury with it, no swelling, stairs, squats, lunges, sitting with the knees bent for a long time all worsen it, and frequently say their knees pop all the time whenever they squat or sit from stand to things. So there's specific tests that you're going to do are your patellar grind, your quad inhibition, a resisted straight leg raise, and then the mini squat. So mini squat is just to have them do 3. They can hold on something for balance, but you want to watch the angle of their knee. So you're just going to have them go down 3 times like this. If that recreates their pain, that's also positive. But the other thing that they typically do is they go in like this. And so that's, again, that hip abductor issue, and that recreates their pain that way because of it. Treatment is PT, PT, and more PT. And so you want to do quad and hip strengthening, hip abductor strengthening. You can write in specifically what's called McConnell taping. And so that's where they use K-tape and tape their kneecap kind of around this direction to pull their kneecap in, which is typically helpful. You just have to write it in your PT note with it. The more specific you can be with diagnoses, the better. If they go to a UK PT place, they're usually good and independent and kind of doing all these things. If they go anywhere outside the system, it's very hit or miss. So the more direction you can give your therapist, the better. Icing after activity is helpful, so it really does decrease the inflammation with it. So about 8 to 10 minutes is all you need kind of with it. Tylenol or ibuprofen is needed, or other NSAIDs is needed. Some people like to try a brace, so you want to use a compression knee sleeve, but you don't want the hole in it because the hole irritates that patella and the surrounding structures even more. And just with activity, so if they're doing hiking or going to the grocery store for like 2 hours, then wearing it for that, but you really don't want to wear it all the time necessarily. And then consider foot orthotics. So over-the-counter ones, so Power Step are probably the best if you've got really flat feet, or very high arches, because that one has the best arch support. So they're about 40 bucks. John's Run Walk Shop has them here in town. So does J&H, or otherwise ordering off of Amazon or whatever. But those are the same cast as like Dr. Scholl's, and those are way better orthotics as far as the Power Step goes. So easy over-the-counter recommendation. The other thing you see a lot is when it's not just OA or knee pain, but it's pain kind of in this medial area right through here. And so we used to call that his anserine bursitis, but really most people don't get swollen with those bursa. It's more of an issue with the tendon attachment site with it. So they commonly go hand in hand with arthritis and or anterior knee pain, kind of from that standpoint. But you got the insertion of the sartorius gracilis and semi-T, so say grace before T. You remember that back from first aid, but that's the hamstring tendon attachments kind of in order as they go down over the tibia. So it's related to overuse. It's related to really tight hamstrings. It's more common in swimmers, and it's called the breaststroker's knee. So as you're doing that frog kick out, it puts stress kind of all through there. Cyclists and then runners with it. And so with runners and cyclists, they have a very strong anterior chain, but their posterior chain as far as muscle groups are very weak. And so then that puts a lot of needed tension kind of on the front and on its attachments kind of down. So if you stretch out the front, strengthen the back, it puts them in more equilibrium so they're not having that pull with it. Biggest exam part is just that you're just going to have tenderness, so you're going to feel for the joint line. It's not going to necessarily hurt there, but it hurts way more so kind of in that front part of your knee. So right along the tibial plateau and that proximal gastroc insertion. And then sometimes too, activation of the medial hamstrings reproduces their pain. So if you have them when they're seated, pull back against you, but also pull back in the opposite hip direction, that will kind of recreate some of that pain. So looking at anatomy-wise, again, so the bursa sit underneath it and protect the bone from breaking. When you have a land on that side, the tendons overlap the top of it. So the more ultrasound we're doing, we're realizing the bursa aren't actually inflamed. It's just all of that tendon insertion and pulling. Obviously, the gastroc inserts all right through there, so it's a big crisscross of things. And so freeing up both of those structures really help make this better. So typically, they're going to have tenderness all the way up and through here in their adductors and hamstrings, and they won't know that hurts until you push on it. And so they really need to work proximally up here in order to make this part better. So that's why with PT, dry needling is helpful, kind of up in here, doing a technique called Grafton, which is kind of that scraping technique that usually end up bruised. So it's like a deep tissue massage to help release it more proximally. The other bursa that you have with it are the prepatellar bursa and your infrapatellar bursa. So these can mimic effusions, but that's why you want to feel on the kneecap. So if the kneecap is locked down to the femur when you're doing that motion, then that's just bursitis. It's not related to actually knee effusion with it. But frequently, people who land directly on their knee will get this prepatellar bursa that's all inflamed. And then people who do like flooring or kneel a lot get this infrapatellar bursa. And so that's again going to be more tibial plateau down here with it. The suprapatellar bursa is what you get with a knee effusion. So when they have that fullness, that top, that's what you're going to aspirate from to get a joint. That's the one that's going to be swollen with a knee effusion. Arthritis kind of going is by far and away the most common thing that you and I both see, but pretty much everyone over the age of 50 has it, but can be as young as 20. So if you've already had an ACL tear and a meniscus surgery when you were 14, you've definitely got arthritis in your knee by the time you're 20. And so it's just kind of the extent of it that's the issue. Obesity is by far and away the biggest risk factor, and we kind of jokingly but seriously call it crushing knee syndrome. Or little bone syndrome is the other part, but it's literally the bones can't hold the weight of the body. And so when you see that x-ray, it's kind of sitting on top of it. And, you know, BMIs over 40 are definitely at risk for that. And that's what causes the arthritis at such an early age. Sports participation, definitely, just because of increased risk of trauma and significant knee injury, meaning ACL, PCL, meniscus injury. And then previous surgery kind of all increases your risk. So arthritis symptoms are really anything and everything. So most people think of it as that just chronic mild pain. That's never what I see. It's always the acute stabbing, sharp. Sometimes it started with a sudden twisting, other times it doesn't. can radiate up and down your leg, that feels like it's unstable, giving out, buckling, popping, clicking, grinding. Pain is medial, lateral, posterior, around the patella, so literally anything, kind of like lupus. But it feels kind of all in that area with it, and symptoms can really change from flare to flare. So when you look at a knee again, so anterior, lateral, and sunrise are helpful, but more than the other x-rays I have, but you can see this space is definitely narrowed as compared to here. So we know there's a meniscus there in this medial compartment. You don't need an MRI to confirm that. It's definitely there. And so it's more degenerative where it just thins out instead of like the way you get in high school with an injury that tears in half. When you look at behind, you can see kind of the osteophytes behind the patella and how narrow it is this direction too. So treatment is not too complicated, but Tylenol, NSAIDs. If one class of NSAIDs doesn't work, switch to another. So naproxen, ibuprofen are one class, meloxicam is a different class, diclofenac's a different class, Celebrex is a different class. So if one of those doesn't work, try switching because everybody reacts differently. The other part is that some people do get used to it, and so just again switching to a different one is helpful. Glucosamine either works or it doesn't for people, but easy to try. So usually I say try it for a month, see how it's going. My patients say I didn't think it was working, so I stopped it, and then I just was a lot achier. So as long as they don't have an allergy to shellfish, it's completely safe, no side effects, and like $3 for a huge bottle for it. Again, a compression knee sleeve with alcohol can be helpful, just to give some mild external support. You can get bigger knee braces, like a hinge knee sleeve, kind of progressing on as the other stuff isn't working. If they have swelling in their knee, you want to ice it, never use heat because the heat brings more swelling to their knee. So that's usually kind of eye-opening for patients, because the heat makes it feel better, and then their knee ends up more swollen. So icing it for 10 minutes at a time, otherwise just with activity. Cortisone injections for flares when none of the above is working. And then really the long-term part is to really strengthen their supporting structure. So if you look at people and old people in particular, when they're going to stand up, they'll do one of these and then push up with it this way. And so their knees are way over their toes, which is because they have no hip strength. So if they get their hips stronger, it'll take a lot of stress of their anterior knees when they go from sitting to standing. So hopefully you've seen that part, but they can do the get up test. So clasp their arms and stand up, you know they have enough hip and core strength. If they can't do that get up and go test, again, PT will be helpful for more of their core and hip, and also help their gait so they won't be so unstable in your elderly populations. Otherwise, like activity recommendations are kind of avoiding the stuff that makes a lot of pounding until their hips are strong enough to support that. So biking, if their seat fit is correct, but a lot of people have anterior knee pain because they're not at the correct position. So go have a really good bike fit test. Elliptical, for the same reason, usually bothers people, is because their pedals are too close to the structure, and so their knees are going way over their toes with it. So have them move that pedal back is helpful. Walking on a flat surface, so usually downhill bothers people, but uphill doesn't. So obviously outside you have to go up and down, but walking on the grass beside the concrete, as well as just a flat track is helpful. Weight loss, obviously. One thing that's helpful to tell people is you carry 5 times your body weight on your knees. So 5 pounds of weight loss is like losing 25 pounds off your knees. So it doesn't take 100 pounds to have some improvement. It literally just takes a few. Injections wise, there's no magic concoction, but anything, and depends on where you are. We use 442 in sports and most of ortho. Can perform it up to every 3 months. Once they already have arthritis, you're just putting off a knee replacement. So you're not speeding up cartilage degradation that way. And it's actually the lidocaine and bupivacaine that cause the cartilage issues, not the Kenalog with it, not the steroid. That being said, if they're getting 6 months worth of relief, you don't want to inject sooner because it will decrease in efficacy over time. Visco supplementation or the gel injections or rooster comb injections, those are hyaluronic acid. Brand name is just dependent on what insurance covers. Euflexa has a slightly improved rate of efficacy in studies. And so it's a 3-shot series because it's actually made from kind of it's more bioavailable than some of the other ones. But Synvisc is a 1-shot, so we use that a lot just to save patients travel time. You can perform those every 6 months. Prior authorization is required. Otherwise, it's about an $800 shot. So kind of keeping that part in mind. Braces, this is the hinge knee sleeve. So Donjoy is our rep who typically fits these. If they have symptoms of instability, the other thing to get these covered is you just need to document severe quad atrophy, which unless you can do a pistol squat and or have a teardrop for a VMO, everyone has quad atrophy. So that's a good way when they said, I've been doing lots of PT, and you're like, well, can you do a pistol squat? And they're like, no, so you need more PT. So if you just document that, that'll get your brace covered through insurance with it. Otherwise, you have to have like an actual ACL tear in order to get it covered. But severe quad atrophy, you'll get it through. An offloader knee brace, which is a custom fit brace, is helpful for unicompartmental arthritis. So send them over to us if they have just that complete medial compartment that's collapsed, and then we'll get them fit for that because it's a very expensive brace otherwise too, but it does help a lot of people. Surgery is helpful for knee replacements. So the scopes to clean up the cartilage actually increase and speed up the rate of arthritis. So when you're scraping and kind of taking out little pieces of meniscus, that's going to stimulate new bone growth, and that's going to make the arthritis worse kind of in the long term with it. So usually people get 6 months to a year to 2 years at most, kind of after they have a scope when they're middle-aged with it. So in general, we don't recommend, and studies don't really support it. That being said, a lot of private practice do this pretty frequently. So just kind of be on the lookout for that and notice that it may not be a bad thing, but it also may not be a good thing. Indications for partial meniscectomy, which is what they're doing, is a mechanical block. So if they have a specific type of meniscal tear where they literally can't extend their knee and it's locked at like 20 to 30 degrees and it physically won't go any further, that's the meniscus that's stuck in the joint that we need to clip that part out. Otherwise, you have failed conservative treatment with documented meniscal tear with PT and cortisone injections. And then that's kind of one for it as well. But again, knowing that you're only going to get a short amount of time improvement. When you have more advanced OA, so the compartment's completely collapsed on that medial side, that's where we get a total knee arthroplasty. So moderate to severe arthritis, and they fail conservative management. And also they must be a surgical candidate. So that's a BMI of 40 or less. So I frequently have the bariatric surgery discussion with patients. Many of them have chosen to do it, and a lot of times that actually cures their knee pain because they just lose the weight. But we really can't operate unless their BMI is 40, and that's because the hardware doesn't support their weight, again, with that crushing knee syndrome issue. So usually they get stronger before surgery for about a month, and then they continue for 3 to 6 months after surgery as far as rehab goes. By about month 1, they're walking more normally with daily life, and then months 3 to 6 are the more advanced activity, like running stairs quick or walking stairs quickly, kind of walking around very easily, hiking, that sort of thing. So this is what knee replacement looks like. We take titanium and put it on the femoral component. We take titanium on the bottom component that looks like a golf tee, and then it's a plastic component on the patella. All those parts are shaved off. So you've got straight shave across here, straight shave across here, straight shave across the back of the kneecap with it. As you can see, like you want to wait till ideally 50 to 60, because if you need a revision, they're going to have to take more bone off, which is going to shorten that leg length. So why you don't want to do it at 30, for example. Otherwise, they last about 20 years. So if we can get them to 50, most people do fine by 70. Some people need a revision after that, but some people just don't because they're not active enough at that point in time. So the older you can get them, the better it goes. So kind of in review, history is most important. You can usually make most diagnoses, like 85% of the time at least, just by the history alone. Identifying the exact location of pain is helpful. Usually tell patients point with one finger where it hurts the most, because that really dials in there, because a lot of people go, my knee hurts. And so then you think patellofemoral pain because they do this. So if they can really point to one spot, that's really helpful for you to guide treatment. Their mechanism of injury versus just an insidious slow onset is helpful to delineate as far as your differential. PT always helps with chronic stuff, so please send them and work on hip and VMO strengthening. Tylenol really does work well for arthritis and as an analgesic. And again, anti-inflammatories have to be taken for 10 days or more to have the anti-inflammatory component. So if they're just taking naproxen once or twice a week, and they have arthritis and a knee effusion, that's not going to help. So make sure they take it consistently for usually 14 days and then as needed after that. And then if they flare again, 2 weeks at a time, and then PRN after that. Questions? Okay. Perfect.